Hi, everyone. Welcome to this evidence-based mental health hangout here today. I'm Michael Ostacher. I'm a professor at Stanford University, and I have the pleasure of hosting another of our terrific hangouts. Today, we'll be discussing a recent paper and a topic which I think is important to everyone who works with children and adolescents. Pediatric Psychopharmacology, 20 Years of Progress. The discussion today will be led by Samuele Cortese, who's Associate Professor of Psychiatry at the University of Southampton and consultant child and adolescent psychiatrist there. Before we begin, I want to let people know, if you are watching us live, you can ask questions to us using the hashtag EBMHchat. That's hashtag EBMHchat. We'll try to get your questions as you send them. When there's a break in the discussion, please do send them if you have any questions that you would like to ask. As usual, also, our Hangouts are archived on YouTube, so if you want to tell your friends and colleagues about it, you'll be able to watch these offline. I also wanted to give a specific thanks to Veronica Haney and Roxanne Keenajad, who have been our digital assistants behind the scenes while they've both been in training in graduate school and early practice, and they've done a really terrific and wonderful job for us for the past 2 years. Andrea Cipriani, our editor-in-chief, will not be joining us today. He's in the midst of some travel, but we'll get off the ground today by having Samuele introduce our participants, and we'll get the discussion going.
Sure, thanks, Michael. Hi, everyone. So I'm very pleased to introduce our guest speakers for today. So Professor Benedetto Vitiello from Turin University, Italy, is a professor of child and adolescent neuropsychiatry, and he has worked for a long time before moving to Italy at the NIMH, where he was in charge of the branch on the treatment, of pharmacological treatment for children and adolescents with mental health problems. And then the other speaker today is Professor Jan Buitelaar, who is professor of child adolescent psychiatry in Nijmegen in the Netherlands. And we are really very pleased and honored to have these two speakers today, because they are really two eminent figures in the field. So actually the paper we are going to discuss today is a part of a special issue which was published by EBMH last year in November, and to celebrate actually its 20th anniversary. And it was a special issue on child and adolescent mental health, edited by Dr. Carlson from New York, Dr. James from Oxford, and by myself. And the main purpose of this issue was really to highlight the advances, but also the challenges and the perspective in terms of future research in a number of areas in child-adolescent mental health. So one of these papers was written by Professor Benedetto Vitiello and his colleague, Dr. Chiara Davico from Turin. And we were really pleased to have this review in our special issue, because it's really comprehensive and thoughtful. And so at this point, I think I will invite Benedetto to provide a summary of the main key points from that paper, and probably highlighting really the advances in the field, but also the challenges. And then I will invite Professor Buitelaar to comment, and then we will open the discussion. And you are welcome, of course, to send questions and comments. Thank you.
Thank you, Samuel, for organizing and for chairing this very interesting hangout. So the topic is use of psychiatric medication in children and adolescents And the first thing I want to do is to acknowledge the fact that we made a lot of progress in the last 20 years, and this is evident if we look, for instance, at how many randomized clinical trials of stimulants were ever made through 1998, which was 6, and to compare that number with the number of the trials that were actually published and completed, obviously, after 1998, which is more than double. And even more, if we look at the number of participants that were randomized in this Swiss trial, we see that the number has increased at least fivefold, so from 2,000 to 12,000 and more. So even for a class of medication like stimulants that was very well known for decades, the number of trials has increased dramatically, and even more, the number of the size of the studies has increased. This effect is even more evident if we look at other classes of medications that are commonly used in the community. For instance, we look at antidepressants for the treatment of depression in children and adolescents. Only 10 trials were completed through 1998. And these trials were primarily single-site, small trials that didn't really have enough statistical power to address the primary questions of the study. Since then, in the last 20 years or so, we had 24 randomized clinical trials completed and published, and the number of participants randomized has increased basically tenfold. So we have more than almost 5,000 children and adolescents randomized to these trials as compared to less than 500 in the previous period through 1998. Other conditions, like in anxiety, this concept is even more striking. Anxiety is one of the most common psychopathology in children, and it is important also because it's often set the stage then for depression later on. So it is very important to treat it as soon as possible. And through 1998, there was only one randomized clinical trial that we could identify that was done on antidepressant in children. And on the contrary, in the last 20 years, there were 12 trials for a total of 2,000 subjects. If we look, for instance, at antidepressant for obsessive compulsive disorder, we see here it's not so much the number of trials that has increased, but the size of the trials. The trials now are multi-site and they have larger sample size. And so they're more able to be informative about the effects of medications. If you look at antipsychotic in schizophrenia, same thing. In the last 20 years, there were basically 3 times as many trials as had ever been done through 1998. This for a class of medication, antipsychotics, that includes both first generation and second generation, obviously, antipsychotics. So antipsychotics have existed since the 50s, and schizophrenia has been with us, unfortunately, for even for a long period of time. Still, only 6 trials were available through 1998, with only a few hundreds of participants, when actually in the last 20 years, there are almost 3,000 youth that were randomized into these trials. For bipolar, here the situation is really extremely dramatic, meaning that there were no randomized clinical trials on bipolar disorders in children or adolescents through 1998. This reflects the fact that the concept of bipolar disorder is in children and adolescents is relatively recent. And so this explains basically that there was no control research 20 years ago. And in the last 20 years, there were 12 trials with 2,500 subjects randomized. For conduct disorder or irritability, even here we had really a major increase in the number of trials. We know the antipsychotics are oftentimes used to treat non-psychotic conditions such as conduct disorder, aggression, irritability. And so this topic is particularly relevant to the treatment in child psychiatry. So these are basically the slides that I wanted to present to introduce the talk, acknowledging that progress has been made. I have then to add that progress has been made primarily on medication that were already used in the community in some way, that clinicians start using these medications off-label. And then researchers realized that they needed to provide the data, control data, to provide support for this use. But this is really part of a discussion that we're going to have now.
So thanks, Benedetto. These are very important figures, and I think you made it clear that really there's been a change in the number, a list of trials. So we can comment, of course, on these and other aspects of your review, but at this point, I would like to ask Jan to comment or to ask any relevant issue to Benedetto to open up the discussion. So Jan, if you can start. You can unmute probably your microphone and thanks.
Yeah, thank you, Sam. Thank you, Benedetto, for the opportunity to discuss your very important paper. It's very interesting, of course, because you have also been in the United States, and from the perspective of our, let's say, colleagues and collaborators across the ocean, and now you are back in Europe. And I think, how do you see the, let's say, the emphasis, the relative emphasis on psychopharmacology in child and adolescent psychiatric disorders in the Northern American continent versus Europe? My feeling has always been that in general in Europe we're slightly more hesitant, slightly more waiting for maybe non-pharma interventions, whereas our American colleagues are, let's say, to put it in plain words, slightly more aggressive. They are more inclined to prescribe medication. If the medication doesn't work, in 5 days they choose a second medication, or they have polypharmacy. So what's your perspective on that?
Certainly there are cultural issues. If we these are basically medical cultural issues that are significant. And I have to say, there are also geographical variation within the United States. The prevalence use of medications changes substantially also from certain areas of the country in US as compared to others. So it's not so homogeneous. But in general, yes, in the United States, there is a greater use of medication for different reasons. And it's not really limited just to psychiatric medication. In general, the Americans are greater consumers of pharmaceuticals. Is also one of the few countries in the world where a pharmaceutical industry can advertise directly their product to the public. In a large part of Europe, I think, most of Europe, I suspect, pharmaceutical companies can advertise their products, but only to physicians. But in the United States, you can see ads in magazine where the consumers are informed about these treatment options and are sometimes urged to get in contact with their physician and to discuss this opportunity with them. And this is significant. It's just a sign that the culture of the use of medication in general is quite different.
Yeah, it was as if you could read my mind, because my next question would have indeed been into your idea or your reflections on where the progress, because it's very clear that the one area more than the other you see over the past 10 to 20 years, you should really progress. Better studies, larger studies, more studies. But what is now the driving force? Has the driving force been input by industry? Because, you know, in particularly in the field of ADHD, there have been new medications. Then industry is going to license these new medications. That gives a strong push on higher quality studies that have to be fitting regulatory requirements and so on. And or is it also academic? And how do you see the, let's say, the pros and cons of, let's say, industry sponsored high quality studies but still sponsored versus investigator initiated, let's say, trials that are really driven by academic curiosity or academic scientific interest? I put it now in a little bit black-white contrast. Of course, you can have merging interest, but I'm like to have your opinion on that.
I think this is what you ask is a very interesting question, meaning or elements for discussion. Indeed, a lot of research has been done driven by the need, the public health need, to explain if mismedication that were used already in the community off-label had efficacy and were safe. So it was really public service that was needed. And because of that, a number of incentives has been created by the US Congress. And 10 years later, in the early 2000s, they were duplicated also in Europe, but they started in the US Congress. So there was actually legislation that gave incentives to pharmaceutical companies to produce these studies in pediatrics in return for an extension of the patent life of a medication of 6 months.
Yes.
And 6 months from a blockbuster medication is a lot of money.
Yeah.
So in that way, basically, the incentive was very effective in increasing the production of these clinical trials. As to the quality, the question that you ask, what is the quality? Sometimes, these studies were produced really for the purpose of getting the extension, and even if the quality followed what was the state of the art, there were limitations, obviously, and so it can be criticized, some of these studies methodologically. But all in all, I think it was an operation that was successful in producing a large amount of data, so that now we can do a number of meta-analyses that were not possible 10 or 20 years ago. It was basically impossible to do it. And now we have meta-analysis basically on all the major medications, also in children.
Yeah. I'm also asking because, for example, I'm not quite sure how it is in all the countries, but for example, in the Netherlands, our Medical Research Council does not at all fund any scientific proposals, any grant proposals on medication. So if, for example, you like to compare from an academic interest, you would like to run a comparison head-to-head comparison of 2 active medications with placebo. They say, well, this is a task for industry, and even proposals for, like in the MTA study in the United States, where we have the comparison between ADHD medication, psychological or behavioral treatments, and then a combination. Such a study would never be funded in Netherlands, because they say, well, the medication part is not should be funded by public means. That should be funded by private means, because then public means are used to improve the database for medication, but that's a commercial issue, and so on and so forth. So what's your perspective on that?
I can see that perspective, but I still believe that it is there should be a public health need to make comparison between different treatments.
Yeah.
And pharmaceutical companies will never really do it because it's not part of their mission or their task.
Yeah.
You know, their task is to promote their product, but not necessarily to compare, let's say, if antidepressants are better than psychotherapy,
Yeah.
or if combining psychotherapy and medication is better than using medication alone. So
Yeah.
these are questions that are very important from a clinical point of view, and therefore from a public health point of view, but they are not part of what industry
Yeah.
will be interested in.
Yeah.
And so I can see a role of a public funding agency to support this kind of studies in the public interest.
Yeah, and fortunately, the European Union has other perspective. So as you know, I and also a large group of collaborators in Europe, like Ian Wong, David Cockhill, Alessandro Soudas, Tobias Barnaszewski, we were funded some years ago to run the Duce project, and that was a project funded by the EU, and that was in fact initiated by political pressure, because you know in Europe there was then a large discussion about long-term safety of stimulant medication, and then in the European Parliament and so on, there was really, they said, okay, this should be funded. So we were funded to look at all aspects of long-term safety. So the cardiovascular aspect, the effect on, let's say, subtle signs of psychosis, mood disorders, loss of creativity, and so that's on the very positive side, and that was very helpful to get a more refined, but also much more balanced, and in fact ultimately reassuring view on that. Yeah, there are of course always kind of exceptions, but in general, long-term safety is much better than was claimed by some, let's say, critical people for medication. So that was certainly done. I like also to raise another point, and that was a little bit illustrated 2 days ago when we saw a new paper, a result of a study in which there was a group of children with autism treated with vasopressin. You know, vasopressin is a kind of neuromodulator, neurotransmitter, also neuropeptide, and it's affecting kind of the social brain system. So it's closely linked to also oxytocin. And that group showed that in a rather small sample of children, there were striking improvements in social behavior, even in the magnitude stronger than the effect of stimulants on ADHD. So we would always say the stimulant effect in ADHD is the most powerful psychopharmacological intervention we have. So effect sizes of 1.5. So really great. We have to temper enthusiasm because, you know, proof of concept, 25, 30 children, we need at least 2 very large multi-site independent studies to get to regulatory agencies. But what I like to bring in is more the public debate that immediately came, at least in Netherlands, from families and patients with autism. Because then they said, wait a moment, is autism really a disease? Or is it a handicap? And yes, but do I really suffer from my social impairments? Most people with autism would say, I'm more handicapped by anxiety, irritability, by my sleeping problems, by my temper tantrums, by my rigidity. And so this creates a new debate about, let's say, normalization and neurodiversity. And so you see that if you have new scientific findings, which are, of course, on a long way bringing those to the clinic, but still now is already the debate, how can we absorb these ideas in the clinic, and how will that influence, let's say, our view on the disorder, but also let us rethinking what's really the need for treatments.
Yeah, that is linked also to the cognitive enhancement, to the fact the stimulants enhance performance, regardless if you have attention deficit disorder or not, and
Yes.
therefore the fact that are oftentimes used just to improve performance.
Yes.
And not really to treat attention deficit disorder. That is an interesting debate, and is germane to pediatric psychopharmacology, obviously, is not limited to that.
No.
It's a very important debate, obviously.
Yeah.
So, and may I ask a question for you, but also for Jan, of course. So, coming back to what you were saying at the beginning, of course, there's been an increasing number of trials over the past 2 decades, larger trials, but have this trial been really informative for the daily clinical practice? And if not, what do you think is missing there? And how can they move into the direction of being more informative when clinicians read the literature and they are making decisions in terms of treatment choice and discussing with patients? So would you say that this body of research has really been informative and influential?
On the whole, I would say yes, it has been informative and it definitely has been influential. Think for a moment only at the data on safety. All the debate about the metabolic adverse effect of antipsychotic medication, of a possible suicidality that has been associated with the use of some antidepressants in adolescents. So there has been a certain amount of information that has been derived by that. Also, we have realized that a number of these medications are less effective really than we thought. The effect of antidepressant medication in depression, after all, in children is very modest, as a number of meta-analyses have confirmed. So they're not really that panacea that maybe we thought about 20 years ago, even though they maintain a certain amount of efficacy. It seems to me that what has been lacking so far is a body of research on practical trials, meaning of trials done not in research settings, but in practice settings. There have been a few of them done, but not enough. Just no more than 3 or 4, I would say, overall. And so that's really what we need, is that type of trials that compare in ecologically valid designs practical treatment that are used under usual conditions, administered not by researchers but by clinicians, and using outcomes that are clearly meaningful and not just limited to rating scales of symptoms.
Yeah, I would like to add to that. So I think at least one limitation of not all, but many studies is, of course, they're still restrictive in an exclusion criteria. That's defensible because the companies like to have, and also to a large extent in response to requirements of FDA and EMA. So they set in an exclusion criteria, but from that, there is a risk that they exclude the typical patients we see in clinical practice who has not 1, but 2, 3, 4 comorbidities, and maybe just subthreshold for a DSM classification, but being significantly impaired. And we all know I would say at the one hand the tragedy, but at the other hand also the problem that for many or even most trials with antidepressant, suicidal patients with depression are excluded, whereas suicidality is the most striking and the most severe symptom of depression. So supporting Ben, yes, indeed. So the risk is that the patients included in these regulatory studies are not completely generalizable to this patient we see in our clinical practice. Then, of course, there is a strict scheme of visits in the regulatory trials, our colleagues, our clinicians, our investigators have been perfectly trained. They have to adhere to certain rules. They have been trained in all the outcome measures. And then when we then move to effectiveness studies in real practice, they are less, but also our clinicians have not a scheme to see the patients every 1 or 2 weeks like we do in the regulatory studies. So then it can happen that after 1 year after the medication has been licensed and introduced in clinical practice, our colleagues from clinical practice say, I'm not so impressed. I don't believe these effect sizes. And then I think the third point, and maybe from my personal interest, maybe even the most important, is that these RCTs do not allow in any way to move towards personalized medicine. These are group-based statistics. Hardly any biomarker data have been collected. Biomarker not only point to genetics, so for pharmacogenetics or risk genes for the disease or the condition, but I also mean like subtyping or stratification by cognitive measures or MRI or EEG. I know that's still far from the typical clinical office, but the whole thinking is that we say, okay, it's good that we have a group effect and an effect size, let's say 0.5, 0.8 or whatsoever. But in our clinical practice, in our consultation room, we have just one patient and or his parents or her parents, and we have to start with a treatment recommendation for that one patient, and then we have very little data to be guided. So of course we know for some comorbidities that can lead to some adaptations for pharmacotherapy, first or second line. We know that age can be a factor. Is still little known about gender. Are girls or boys equally responsive to medications? For some medication we know, but not for all. Or is dosages gender dependent or sex dependent? And so I think particularly moving towards personalized medicine and then working with biomarkers, we have still many gaps in our knowledge base for this.
Thanks, Jan. So do you want to comment any further, Benedetto?
I totally understand, and I agree that these trials are basically there are experiments that are set up to answer well one question. And this is the limitation, obviously, of clinical trials. So they are basically addressing one primary question. So all the others remain important questions, but they don't have an answer. I think that the future in child and adolescent psychopharmacology should be in exactly what you're saying, Jan, meaning in personalization, in hypotheses that are built on mechanism of action of psychopathology that are being clarified by neuroscience, by the identification of new targets that are linked to the psychopathology, because so far it has not been so. So far we can basically use medication that were found through serendipity, first in adults and then applied to children. So it has been fairly pedestrian in some way, very useful, very practically useful up to a certain point, but certainly very limited. So that's what I try to basically emphasize in the paper that was published in Evidence-Based Mental Health, is that child psychopharmacology is a new discipline, is a new area of research, and so far is still in infancy, because the future belongs to applying basically neuroscience to developmental psychopathology. How to do that, is less clear, but let's talk about that.
Yes, yeah.
Good. So I guess so far we have talked about randomized controlled trials, but Of course, there are also data from population registry-based and large epidemiological studies. So any comment on this and strengths, weaknesses, and is it possible to integrate in a way information data from randomized controlled trials and population-based studies?
Well, I can go first, and then I see what Ian believes. I certainly think that these large databases are a very promising way of identifying uh, treatment effects, not necessarily to prove efficacy beyond any reasonable doubt in a way that like Food and Drug Administration or the EMA probably will accept, but certainly providing information that can be very convincing from a practical point of view. I'm thinking about, for instance, the studies that were done with the Scandinavian databases or the large databases in North America, with analysis in particular within subject. So the same subject, so off medication or on medication. As it happens, patients sometimes stop their medication, sometimes they're not compliant or they decide not to take them. And if a database includes all the possible outcomes that can happen to these people, like car accidents, suicide, antisocial behavior, one can, as it was done, found links and association between use of medication or not use of medication and negative outcomes in the same subject. So controlling for all the genetics, all the other personal variables, except for time, obviously, because we don't randomize. These are not randomized trials, so they are naturalistic interruption of treatment. But the results are fairly tantalizing, I would say, and to my point of view, they contribute significantly to what we know about medications. I wonder what Ian think about this.
Yeah, I agree. These well, we have always had like post-marketing surveillance, but that was a very loosely defined paradigm because I know that the medication was then licensed, and they said to the company, "Oh, of course you should develop a plan for post-marketing," but that was like was not very strict, was not very regulated by definition. So these Scandinavian case registers in particular, they are fantastic. They are fantastic for several purposes. First, you have rare events. You can have very rare events that you can never model in a clinical trial because the incidence rate is low and you need a large number of exposures. Two, you can have events that you didn't anticipate. So you can have unexpected, but still severe or significant or relevant events. Third, these events come after a long interval. So clinical trials, we have 12 weeks. We have, of course, also discontinuation, withdrawal designs, and so on. But overall, they are mostly like for 6 to 12 months. And so for every long-term event that's after a long time or rare and or unknown or unanticipated, you have to rely on these databases. And then the limitation is, of course, that these are clinical cases that have been stamped off in a hospital system. They have not been diagnosed according to prospective criteria, but nonetheless, you capitalize on big data with some noise. But the advantage is you may analyze very interesting signals. I'm even now involved in some new projects in which we use these databases to create new hypotheses about potential new targets. So for example, we have some hypotheses about also the relevance of the insulin signaling system in some disorders. And now we are trying to get information from these databases, whether patients that have been, for example, treated with diabetes 2 medication, which affect the insulin signaling system, whether these medications have unanticipated spin-off effects on other domains of functioning. And so this is then in the discovery pathway, not in the testing pathway for side effects, but in the discovery pathway to think about potentially repurposing existing medication or creating a new hypothesis. I think there is still a third way of data that's important. So we have prospectively designed RCTs, we have Scandinavian case registers, and so on and so forth. We have insurance databases like in the US, but also I think still prospective observational studies, so not randomized per se, but prospective observational studies are extremely important. I think these are probably more the studies to help us in developing and testing biomarkers than the RCTs. So for example, if you carefully would assess, let's say, children with conduct, ADHD, also depression, psychosis, baseline with a certain set of potentially interesting biomarkers, and would just carefully document their treatment history and their treatment outcome, this again can you facilitate on the discovery pathway to certain biomarkers, and whether a biomarker stratifies or is a predictive, is predicting the outcome. And then at second stage, this has to be then retested or replicated, maybe in controlled studies.
Yeah, I agree. And again, so the value of the studies is not only in demonstrating safety or efficacy or effectiveness, but also in generating new hypotheses, identifying new targets, especially in the area of personalization. I think what is critical is to have a large number of patients that is representative. So we try to minimize any selection biases in that sense. And then to have a systematic follow-up that is done prospectively for extended period of time. These are not cheap studies to do, so they require a substantial amount of investment. The Scandinavian database analysis, after all, the cost of that is the data analysis that are very sophisticated, also quite expensive, but not in the data collection. So it's more in data management. But obviously, when you have a cohort of thousands of patients in the population, then that requires a large investment of funds for doing that, obviously.
Yeah, I like to add some other points, and we didn't discuss so far, but we have still, I think, also unused opportunities in terms of our potentially new digital phenotypes and digital outcome measures. So typically, we interview the patient, we do CGI, we do all kinds of standard instruments, but these aggregate the behavior or the symptoms over 2 weeks or 4 weeks. But it's very likely that some aspects of psychopathology are not just your average symptom count over 2 weeks, like with a questionnaire. It could be that the real problem of a patient with anxiety is that he or she is super anxious at the end of the afternoon or 2 hours a day, and that the average anxiety level is not quite spectacularly deviant. And the more spectacular example is, of course, patients with irritability or borderline personality disorder characteristics. These may be extremely aggressive and irritable for some hours a day, and it's more probably the amplitude of their deviation from normality, the amplitude, rather than the constant level of being deviant. And so using digital measures which are also ecologically valid, so they are not illustrated, they are more ecologically valid in terms of that you sample these symptoms in natural context and so on. They are use sample continuous, not episodic, like with most questionnaires. So we didn't use sufficiently, I think, these digital phenotypes and digital measures to have a more broad scope of outcome, and that will also allow us to move, let's say, more not only to better assessment of symptoms, but beyond symptoms, and to issues like quality of life, impairment of functioning as a result of pharmacological interventions.
I was going to ask a question, and Sam or Ben, please repeat this if Jan does not hear me. But so when you're talking about
the technical point is, of course, we have hundreds and thousands of these apps, and so we probably need a little bit standardization.
Yeah, I was going to say
that because otherwise every clinician or every research team has his own favorite app, and still this would also hamper generalization of our findings.
Right. So there is a question now, Jan, from Michael. I will repeat.
So Jan and Ben and Sam.
I cannot understand Michael.
We'll repeat it to you. Tell him that.
I will repeat the question for you, Jan.
Yeah. So when you're looking at biomarkers or other predictors to try to more, I guess, personalize or make more precise who is going to respond to a treatment or not, I think all the things that you're saying seem to point to there being a multifactorial approach to that in terms of predictors, not a single biomarker, for instance, being a predictor, but multiple predictors together in a model being used to predict response. And that seems very difficult to study, but that seems much more possible than, I think, expecting a single biomarker to be predictive of anything, especially in these complex behavioral disorders.
So, Jan, the common question was really about when you try to use biomarkers to predict a response. Looks like it's very likely that there is a set of biomarkers rather than an individual single biomarker, which of course make the study more difficult, and it makes this more difficult and challenging to study. So any comment on that?
Yeah, well, the biomarker discovery pathway is very complicated. I have some experience with that now in our European studies with autism. So we were in autism the first who went to EMA before starting collecting biomarkers. So we did the same as pharma companies. They don't go to EMA or FDA when they have a fantastic trial result. They go to EMA and FDA when they are developing the protocol. They get feedback on the protocol, and then when the protocol is approved, they're collecting the data. And so we did the same for some of our studies in autism. We went to EMA, we submitted our protocol for proposed biomarkers. These range from, let's say, eye tracking EEG to serotonin in blood and many others. And then they give advice. So that already illustrates that that's a process of at least 5 to 10 years. And then is not only the academic side of the biomarker, but it's also indeed feasibility. So a biomarker, an MR biomarker, MRI scanning biomarker, or let's say brain volume or thinner cortex in the prefrontal lobe, is academically super interesting, but is of course not very feasible, because I know a few clinicians who have a MRI scanner in the garden and to scan the patient, but it can be helpful for the discovery, and the biomarker also brings about health economics aspect. So if for example a genetic or pharmacogenetic screen would and that has some cost, the pharmacogenetic screen. But if, as a result of a pharmacogenetic screen, this gets you, for example, in terms of antidepressants, at a more chanceful first choice for an antidepressant, which reduces time to recovery or remission, that will save costs. we all know that clozapine is still the medication for severely treatment refractory schizophrenia. We also know we have the problems with the safety. But if we would find a biomarker that would a priori select a subtype of schizophrenia, in which we would say, for this, clozapine is the first line treatment, and then we can make a health economic assessment and say, well, this is really cost effective, and so biomarkers are closely linked to what we call context of use. Context of use is it a diagnostic, is it enrichment, is it predictive for safety or long-term side effects? So it's a completely other game than just looking at efficacy. And I agree, it's not like, oh, tomorrow I have a fantastic paper with eye tracking, I plug it in the clinical system and is ready. Is a really long-term path, is also tapping on acceptability by clinicians. So we as an academic working psychiatrist, we have then to talk to our clinicians and really probe for, do they believe in the system? Do they believe in the result? Can they explain this to the patients? And so this is a very long process. Agreed.
Any comment, Ben?
I think biomarkers is certainly a fascinating area in medicine in general. Remains a promise and remains really a hope, except for certain areas in oncology, where actually personalization and biomarkers is really critical to guide treatment. So it's amazing how you can basically, based on the characteristics, the biomarker characteristics of a tumor, of a neoplasia, of a cancer, the treatment can be really individualized in some conditions with remarkable effects. So, but besides that, it remains a promise. And I think in mental health is particularly difficult. I agree with Ian, it would be great to get, not impossible, not theoretically impossible, to get biomarkers that can tell us if you should use clozapine or not, and if you use certain medication rather than others, serotonergic agents rather than adrenergic agents, and so forth. I hope eventually that we can get there. I still don't know exactly the path, but it's really very promising.
Yeah.
Thank you. So I guess another aspect is the fact that, of course, this is a hangout on child psychopharmacology, but many points, I guess, we discuss apply equally to adult psychopharmacology in general. And I think it's good we have on the panel Michael, who's an adult psychiatrist. So in your opinion, are there any specific challenges in child and adolescent psychopharmacology in relation to adult, and also possibly any opportunity from child adolescent psychopharmacology which we do not have in adult psychopharmacology?
Oh, that's a really
everyone. So yeah,
that's a really hard question. I mean, I think the concerns with children are about safety, and I think that because of the developmental complexity and environmental complexity of children and how they express their symptoms, even more so than adults, makes diagnosing and treating children much more difficult than with adults, and also makes treatment development, especially drug or somatic treatment development, much more fraught than it is in adults. In other words, there's much more to lose. But also in adult disorders, we struggle with this all the time. We enroll people in studies, they've had the disorder for 3 or 4 decades. I mean, what do we think that we're going to do to treat them that's going to have an impact on the course of the illness? You know, you look at studies, we have studies, I mean, I work at the Veterans Administration hospitals. We have studies where the mean age is over 50 years old in studies, or nearly 50 years old. And so it's much more complicated. I think like this vasopressin study this week is very interesting. Whether anything will ever come of it is completely, unpredictable, I think. Hopefully it will mean something. And I think that the points that Jan made about whether or not autism is a disorder or a disability, what it actually, or a handicap, what it actually means is really important. In terms of what the child world can bring to the adult world, I think is trying to think about understanding adult disorders from a developmental perspective and really being careful about trying to study them earlier in life rather than later in life. And so the work that they've done in schizophrenia, John Kane and his group and others who have worked to try to look at complex interventions earlier in life, I think is something that we in the adult world really need to look at, because the idea that we're going to find a magic drug that's going to have a really important impact on psychiatric disorders in people who are in their 5th or 6th decades of life is really, really problematic. I hope that, I don't know what other people think about that, but that's sort of my main comment.
Yeah, no, that was really thoughtful. So Jan, Ben, we have probably 3-4 minutes before finishing. So any final, if you want to add to this, or any final considerations?
Well, since Jan didn't hear a word I said, I won't expect him to comment.
So if you want to comment, so basically, yeah, I think Jan, so basically Michael highlighted that, of course, the difficulty with children is around ethical concern, but also the opportunities that, we see the disorder from the beginning. So it's not, we are not talking about patients who have been having the disease for decades, where clearly the management is more difficult. So any other final considerations on this point, or more generally on psychopharmacology in children in terms of advances and challenges and perspectives?
I definitely agree with Michael that in childhood, in adolescence, we have an opportunity. We have an opportunity to change the trajectory of psychopathology, and to do this, it's great. We still don't know how to do it exactly, and what is even more difficult is we still don't know how methodologically we can prove that we have done so. Because maybe we are able to do it, but when we need to prove it, and that it's quite challenging, because definitely you cannot have randomized clinical trials that last 20 or 30 years. But there may be some way to arrive at the conclusion that early treatment translates into a better prognosis. The concept of untreated psychosis, for instance, gets close to that. The longer is the untreated psychosis, and the worse seems to be the functional prognosis later on. So it's not really a definite proof from a randomized study, but it's an association that is certainly very convincing from a psychopathology point of view. So it's just an example, but I would like to see more of that. We use a lot of stimulants for treating attention deficit disorder, but still we don't know if use of stimulants early on in the disorder translate into a much better prognosis later on. Not just a little bit, but really changes substantially.
Right, employment, relationships.
And maybe we do. Maybe using Ritalin early on changes the opportunity that the child will have later on. But how can we prove it? There is also an issue of methodology behind that.
Yeah, thanks. Yeah, Jan.
Yeah, I'm linking to that comment by Ben. My interest is to some extent also at the very early years of life, so early autism, ADHD, and there we have, of course, more special, even ethical concerns. Can you treat preschoolers as medication? What do we know about the safety? We know that the rule of thumb is that the brain is more plastic at early ages, but more plasticity may also be implicating more vulnerability to toxicity. And so this has two sides. We also probably have to more thinking about biological, but not per se pharma interventions. Let's say I'm very interested and work also on ideas about that with these early developmental disorders. It's the disbalance between excitation and inhibition in the brain. That's kind of the final common pathway. I would say this is all proven, but there is also indications that you can modify that early excitation inhibition imbalance by food, by some substances that we have seen these also high impact papers on that use of vitamins and some food, folic acid and so on during the pregnancy reduces the risk in the offspring of the neurodevelopmental disorders. So this is fantastic work. And so you have biological impact. You try to intervene early, and not per se also with medication, but with biologically well-funded neuroscience, biologically driven interventions. So I think this is also some aspect for our work, future work in the next couple of years.
Yeah.
All right, we're at the end of our hour, so I would like to close out. I think this has been a really remarkable and lively discussion. I hope everyone watching has enjoyed it, and I hope the participants too has enjoyed it. I wanted to thank Benedetto, Vitiello, Jan Buitelaar, and of course Samuele Cortese for putting together this terrific discussion about the last 20 years of pediatric psychopharmacology. Thank you for joining us again. I wanted to thank very much Veronica Heaney and Roxanne Keenajad for all the work they've done behind the scenes. Thank you so much. I'll miss working with you terribly and wish you terrific success in both your careers. I'm Michael Ostacher. I'm signing off for Andrea Cipriani, the editor-in-chief of EBMH. Thank you very much.